Good afternoon. After such a good lunch, we need we need to start. Thank you very much for coming. It gives me a pleasure to start the third session for today, and it gives me the pleasure to welcome Dr. Abeer Zeitoun online. She is a skilled specialist in medication and patient safety and with extensive experience in the field of public safety. Currently, Dr. Zeitoun holds the position of clinical and technical manager at the Lebanese National Pharmacovigilance Program. She has more than 15 years of educational expertise, and she held the role of clinical pharmacy assistant professor at the Lebanese American University. Just to tell you that this subject is for sure of highest importance for us all as anesthesiologists, especially now with the problem of medication error that's happening all over the world. So I'm sure the navigating challenges through knowledge advancement related to this subject is very important. Thank you.
Good afternoon, everyone. It gives me a great pleasure to be with you today. And in my following presentation, I will be sharing insights about medication safety in anesthesia practices. My name is Abeer Zeitoun, and I am the Clinical and Technical Manager at the Pharmacovigilance Program at the Ministry of Public Health. As an outline for my presentation, I will be starting by an overview on patient safety and focusing on anesthesia medication errors and safety measures. And this will be followed by prevention strategies, where I will end up with an important concept, just culture. Before I start, for those who are not familiar with the inception of the National Pharmacovigilance Program, this program joined the International Drug Monitoring, PIDM, as a full member in 2021, with the mission of safeguarding the health of Lebanese population and the vision of improving patient safety. Our small team, under the leadership of Dr. Rita Karam, the coordinator and director of the program, and our dedicated PV officers, Dr. Aya Brahim and Sarah Sayed, with our consultants, Dr. Miriam Watfa and Dr. Katya Iskandar, we were able to achieve in this very small time several achievements. First, we have in place several reporting tools. This was backed up with a process for handling perceived adverse events, creating a channel for communicating those safety findings. This have been manifested by releasing safety reports, regular newsletters, sharing through publication, spreading awareness was another activities that we have conducted at the level of hospitals, community pharmacies, and students. And lately, we have released the Lebanese Good Pharmacovigilance Practices Guidelines for our market authorization holders in Lebanon. So without any further delay, I will be starting with the first item on our outline for today, patient safety. As any healthcare providers coming every day to our practice, the first thing that we have in mind is first, do no harm, as one of the principal and crucial belief that we all practice on daily basis, with our unconsciousness applying patient safety that is defined as the absence of preventable harms to patients and the reduction of risk or unnecessary harm associated with healthcare to an acceptable minimum. And yet, there is compelling evidence in the literature of the burden of medication error on our healthcare systems, where around 1 in every 10 patients is being harmed in the healthcare. And in low to middle income countries, we have as many as 4 in 100 people who die from unsafe care, with more than 3 million deaths occur annually due to unsafe care, with those being in 50% of the cases preventable harms and in 50% of the cases attributed to medications. As for Lebanon, what is exactly the size of the problem? In Lebanon, data regarding the exact number of the reported medication errors is missing. Studies that are available yet are outdated, or they involve a small number of patients and consequently are not reflective of the Lebanese health care system and could not be considered as a representative data. This is backed up with the data received to our national program, where looking at the number of the case reports received to us during 2023, we find 174 case reports allocated to medication errors, out of which only 24 cases were accessible and were contributed to incorrect dosing. So what are the different sources that can contribute to patient harm? In healthcare, in daily practices, breaks in our healthcare system are the main problems that contribute in any setting at any level to patient harm, starting with those related to the system and organization factors in place. As we all know, healthcare setting is a complex setting where inadequate process and procedure, disruption in the workflow and care coordination, constraints in resources, inadequate staffing are all factors that can lead to patient harm. Technology factors is another source, and here we are talking about problems with electronic health records or misuse of technology. Another factor is related to human factors, and this is very important, where we are talking about ineffective communication between healthcare workers, within the same healthcare team, with the patients, and ineffective teamwork, fatigue, burnout, and cognitive bias are all examples of human factors contributing to patient harm. Patient-related factors translated in patient limited literacy or lack of their actual engagement in the process of treatment is another source. And finally, external factors like the absence of policies, inconsistent regulation, economic and financial pressure, and challenges related to the shortage in medication are another examples that contribute to patient harm and consequently contribute to medication errors. So when we're talking about medication errors, it is confirmed that 1 out of every 30 patients in healthcare are being affected by an error due to the use of medication, where in 25% of those cases, they are severe or life-threatening harms, and in 50% of those cases, these were preventable harms. What about anesthesia medication? So what applies to all drug classes applies to anesthesia. And an error that occurs at the level of anesthesia medication will make this error of a one moment a sorrow of a whole life, not only for the patient, but also for the second victim or the healthcare practitioner. If we look into the literature, there are several tremendous tragic stories about patients losing their lives because of medication errors and because of cracks in our healthcare systems. And I give here an example, a story of Amanda, an 18-year-old girl who lost her life while she was using the patient-controlled anesthesia in the patient-controlled analgesic while she's in hospital. But due to the lack of effective monitoring parameter, the patient ended up losing her life due to respiratory depression. And consequently, here we had the nurse who was the second victim because of the lack of proper procedure and policies that should have been put in place. So what are the sources of errors alongside the anesthesia medication pathway? Similarly to all medications, error can occur from prescribing to administration and monitoring. But when we are talking about anesthesia medication, we are talking here about high alert medications such as muscle relaxants, narcotics, opioids, and sedatives, where the margin of error is small, and a small error will really contribute to critical outcome. So to shed some examples, to share some example and to shed lights, to shed lights on some of the examples of potential errors that can occur at every single step. We talk about prescribing errors that, for example, if a nurse transcribe morphine instead of hydromorphone into the system, this will lead to overdose. We talk about dispensing error that can be reflected, for example, with misinterpretation of a handwritten prescription and consequently giving an incorrect dose, especially if the prescription include an approved abbreviation. We are talking about preparation and compounding error, where sometimes the use of a wrong diluent can lead to concentration error. We're talking about administration errors that may lead to giving the wrong routes, for example, giving the medication IV of instead of epidural, ending up with adverse effect. And finally, monitoring and documentation, similarly to what we have shared in the story previously mentioned, failure to properly monitor patients' vital signs may lead to delayed detection of adverse event. So what do we know about anesthesia medication errors? A systematic review investigating medication errors in anesthesia between 1980 and 2021 revealed that the incidence of medication errors during general anesthesia were as high as 1.12, where the most common errors were substitution errors and incorrect dosing errors. And for the top most three medications or classes in anesthesia associated with those errors, having propofol on the list due to its rapid onset and potential for overdose, followed by the opioids, where the look-alike and sound-alike made a big room for medication error with this class. And finally, muscle relaxants with rocuronium or vicuronium, where dosage error, administration errors were mostly seen. And most of the data revealed that dispensing those drugs when they were really not needed due to a look-alike errors was the highest contributing to those errors. So what were the sources contributing to those errors? We have three main contributing sources, starting with the human errors manifested by miscommunication, fatigue, and inattention, followed by the look-alike and sound-alike source of error with the lack of standardized protocols or lack of proper training, and the complexity of medication calculation leading to errors in precise dosings and titration were all three contributing main sources for those errors. So how can we prevent those errors from taking place? Well, several institutions and organizations have played an important role in advancing medication safety and reducing medication error in order to promote best practices. And this has been manifested throughout the medication use pathway, where we all know that the errors usually occur are not the result of a one-person practice, rather are due to gaps and cracks in our healthcare system, leading to these errors to take place. Consequently, all of those institutions have several policies, recommendations, guidelines, good practices in order to increase the barriers and to identify the gaps in our healthcare systems, making it less common or more difficult for those errors to align and to take place. Give quick examples in those. I start with the most important cornerstone in the process, which is standardization of our practices through policies and protocols throughout the medication use pathway. Independent double checking is another important recommendation to be performed while dispensing, preparing, or administering the drugs in order to ensure the 5 rights, which is that the right patient is receiving the right drug with the right dose at the right route and in the right time. Effective communication is another important recommendation, especially at the level of monitoring, in order to promote proper handoffs, especially between healthcare providers. And these all can be complemented with the proper use of technology whenever possible, like barcoding and electronic health systems. Also, continuous education to stay up to date, and conducting a root cause analysis for identified adverse event in order to identify the cause of the problem and preventing it from taking place again. What about Lebanon? Despite all those measures that have been recommended, what is actually reported is much, much less than what could be reported. And this have been attributed to the suboptimal training in our patient safety practices, insufficient medical curricula, and the lack of patient safety culture. And this have been also backed up with the data received to our database, revealing low numbers of reports from healthcare providers. So what can we do in order to overcome those problems? At the healthcare professionals levels, we play a crucial role at the micro level in developing an internal reporting system and in actively reporting to the National Pharmacovigilance Program. To do so, we have put in place several reporting tools that you can use to report, most importantly, the e-reporting form and the med safety application. The e-reporting form is available at our website, where you can click on the link and automatically it will take you to a friendly user adverse event reporting form where you can opt to report in an anonymous way. The Med Safety app is another smart tool that can be downloaded from App Store or Google Play, and you can use it at any time and any place in order to report all the details related to patient and to the drugs, again, in a very friendly user way. It's very important to emphasize here that all reports can be chosen to be reported in an anonymous mode, and those received data are strictly confidential. At the level of the Lebanese National Pharmacovigilance Program, we already started with some initiative in order to minimize error. I give some examples like the development of a national LASA list, look-alike, sound-alike products for the drugs that are registered in the Lebanese market, and developing a list of excipients with known effect. We also have raised awareness at different levels. For example, we are currently in the Medication Safety Week, where we were actively participating on all social media platforms to promote patient centricity, to promote reporting, and to promote the importance of playing the role of sharing those adverse events. We have also contributed in raising awareness by conducting on-site focused training at hospital levels and community pharmacies to promote pharmacovigilance culture and the importance of reporting. What is next? Risk minimization measures can be further implemented with your help, with an enhanced reporting process and receiving more adverse reports from all stakeholders. Only then we can have policies put in place in order to standardize our practices for identified gaps in our healthcare systems. Continuously sharing through the Dear Doctor letter updates related to safety concerns identified in these reports, and incorporating those patient safety in our medical curricula. We started with this initiative where we are working now on having pharmacovigilance culture, medication and patient safety culture recommended to be incorporated in our pharmacy curricula. So back up all of these practices, it is very important to adapt the just culture at the micro and the macro level in order to enhance reporting.
2 minutes, Dr. Abeer, we finished.
Just culture. Just culture is a concept where you are ensuring the concept of being accountable and fair while promoting an open reporting culture. How is that achieved? By encouraging reporting in a blame-free yet accountable atmosphere. Learning from using those reported adverse events as a learning opportunity for improvement, holding people accountable for their action in case of recklessness, using a fair and consistent way of handling and assessing those adverse events, and this can be further supported with the trust culture scheme, supporting the second victim and ensuring that those errors are occurring due to a failure in the system where we need to improve the system rather than penalizing the healthcare providers, and providing training in order to prevent those errors from occurring again. All of these will contribute an enhanced reporting culture because people will feel more secure to report at a micro and a macro level. So therefore, just culture is a culture of accountability, empathy, and it's a fair system. With this, I would like to end up my presentation with important take-home messages. You do play a very important role in ensuring the safety culture and ensuring the safety procedures by playing your role in reporting. Teamwork, communication are essentials to minimize error. Engaging patient is one of the fundamental practices that we should all ensure, and continuing to reporting, keeping in mind and without forgetting that the med safety report application and the e-reporting link are there for you to use and to enhance our role in establishing a safer practices culture. With this, I reach the end of my presentation. I would like to thank you all for